Okay, this is Michelle Bullock, licensed massage therapist, and today we're going to be talking about the muscles, including the actions, the origins, and insertions for the pelvis and thigh. This is the 5th video in a 6-part series going through each region of the body, just looking at the locations and the actions of each of those muscles. If this seems like something that you could find useful to prepare yourself for the MBLEx and for your massage therapy studies in general, then stay tuned and we'll get started here in just a few minutes. But first I have some housekeeping. You guys who are subscribed to me, who have already picked up these resources for yourself, you know what I'm talking about. We've got a free study guide, and that's a printable. They're all PDFs except for one class, that course that I have online. But we've got a PDF study guide that goes point by point through what you need to know. I got this from the Federation of State Massage Therapy Boards. So see, we have some client assessment stuff that you need to know. And yeah, you can go point by point and check off everything that you study as you go along. I also have a printable practice test. It's 100 questions. It's not this exact test. This is test 2, and that's part of the 10 test bundle that I have for sale. But it's 10 of these essentially, but all different questions, over 1,000 questions. So look out for that in the description if you're interested. But for a freebie, you get test 1. And that's just all the MBLEx style questions, multiple choice. And then there's the answer key at the end that explains my reasoning for the answers. And then at the very end, you have a topic key where you can circle which ones you got wrong. And that helps you know where you need to spend some more time studying. And then finally, I have a mini course for you. It's called Start Strong, How to Apply for and Prepare for the MBLEx. So it includes some background about how the MBLEx is set up, which might help give you a little bit more confidence in the fact that the MBLEx isn't trying to trick you. It's trying to just make sure that you're ready to put your hands on people safely, and how to go through and apply for it through the Federation of State Massage Therapy Boards, how to notify your school that you're intending to take the MBLEx, and because the Federation of State Massage Therapy Boards wants your transcripts, and then how to prepare for through studying and what to expect on test day. So it's a great little course, 30 minutes in total for the whole thing, and it's absolutely free for you. So look down in the description below for those resources. Now, I have a software for presenting this where I'm going to be showing everything, the bony attachments and the movements of the pelvis and thigh on the computer screen. I'm doing this because the internet can be a yucky place, and sometimes people, make a bunch of comments, or I might get the wrong kind of viewers if I'm up here, if I'm standing there in my yoga pants pointing at my crotch and my butt through the whole process. So I decided to do everything on this anatomy software instead to talk about it, so everything stays, as professional as possible. Okay, and so here we're going to get started with looking at the major landmarks of the pelvis and thigh. We're going to be looking at first the pelvis, and then we're going to move down to the leg attachments that we need to be considerate of. First of all, we have the iliac crest, and that runs along the top of the hip right there, all along the top of the ilium. And we also have possibly some sacral attachments. We do have some sacral attachments that go along the edge of the sacrum. That's that big flat bone or tailbone. Then a little bit of attachment at the coccyx. And then we have some attachments at this is the anterior iliac spine, this ridge along here. The top bump would be the superior iliac spine, and the bottom bump would be the inferior iliac spine. All right, and then some other attachments going along the pubic bone, because the whole hip is a collection of 3 different bones. But the pubic area here we've got the ramus, which is this area right in the middle. So superiorly, that's the superior part. And then the inferior part would be this part down below. It also is kind of on the ischial part. And then we have the pubic crest, which is one right in the front. So if you were to feel down onto your groin and feel that bump all the way in the front under your mound, that would be the pubic bone. And then if you followed that laterally, then you would be on the ramus. And you keep going up, you feel the bump of your hip, then you're going to feel that iliac spine, and then you feel the very top, then you would feel the iliac crest. And then along the bottom, your sits bones, as they say, we have the ischial tuberosity, which is this big lump right here. And that's where you've got a bunch of hamstring attachments. In the back, in this fossa that the iliac crest creates, we have a bunch of grooves that the glutes attach to, and then your piriformis is going to be attaching in there. Coming down to the leg, boop, boop. That leg bone, the femur, we have the greater trochanter, big bump right there. If you reach around to the lateral part, you feel a big bump at the top of your leg. That's your greater trochanter. And then the lesser trochanter is the smaller bump. And then as we move down the femur, on the medial side, you reach inside your legs and you feel the inside of your thigh. There's a very sensitive area where we have a bunch of adductor attachments. You're going to find the linea aspera. That's where we have a lot of attachments on the inside of the leg. Those adductor attachments are going to be in there. And then coming down, we've got the medial epicondyle of the femur. So we've got some attachments there. And then on the tibia, which is the next bone down, is the big one. The little one's a fibula, but the big one is the tibia. And we've got the tibial tuberosity there. And on that flat part, on the medial side, we have the attachments for the pes anserinus. So we have some attachments to that. And that's it for our bony landmarks that we're going to be needing to keep in mind for this presentation as I'm going through the muscles. And I'm hoping to do some movements here on this. And let's see. So I wanted to walk you through these movements real quick. Move this chair out of the way. I know I said I wasn't going to demonstrate, but I was like messing around with the software and it's just way too much work for me to demonstrate it on the computer, so I'm going to do that. But then when it comes to pointing out the places where the muscles attach, I'm going to be doing that on the software. But I just want to walk you through these movements, these actions of the pelvis and hip here. Okay. So, movements of the hip. We've got hip flexion, right? We've got hip extension. That's when you have the glutes engaged and you're bringing that leg back. That's hip extension. Flexion, extension. And of course we've got abduction and adduction, where you bring it back together. Adduction, and then abduction is taking it away. Abducting, taking it away. Adduction, bringing it together. We have two different kinds of rotation. Point this camera down just a little bit so you can see it a little bit better. The two different kinds of rotation that we have are where the knee is going inward, that's internal rotation. Knee is going outward, that's external rotation. Internal rotation, external rotation. So the hip is running, or you say the head of the femur is turning to the lateral side, going to the outside, that's external rotation. So also known as lateral rotation. And then we have internal, which is medial rotation. So the hip is moving toward the center, moving inward. So there's that. And then anterior pelvic tilt. Ah, yes. So remember we were talking about pelvic tilt, where the pelvis is tilting downward, and you're let's say it's a bowl full of pancake batter, and you're spilling it outward, right? That would be anterior tilt. And if it's your pelvis is tilting backward, that would be posterior pelvic tilt. So that's a movement that we have in the pelvis. The psoas does lateral flexion and lateral or a rotation. It will do rotation. Okay, so knees. For knees, we have extension and flexion. Extension and flexion. And then we have flexed rotation, where there's like a little bit of a tilt. Okay, flex, so it's flexed, and then this more than just the ankle, the leg actually tilts just a little bit. All right, so those are the movements we've got. I hope that you could see that okay. Just like it's more than just the ankle, it's the actual leg tilts or twists. Now we're going to go on and talk about the muscles. The first group that we're going to be talking about is the gluteal group, and we're going to start with Glute Max. Well, might as well. So our origin is going to be all across the back hip, over and over, like about halfway up the iliac crest. So let's see, ilium, sacrum, coccyx, sacrotuberous, and sacroiliac ligaments. So it goes all the way down to the tailbone. And then that's the origin, that's where it's stable at. The insertion, where the greatest line of pull is the gluteal tuberosity of the femur, and the IT band, the IT tract. So it attaches a little bit to the leg and a little bit to the IT band. The actions are that it does hip extension, it does lateral rotation, which is external rotation, and it abducts the hip. And then when it works together, when the two glutes are working together, it stabilizes the pelvis and trunk during movement. And the lower fibers do a little bit. The lower fibers, that is like down by the coccyx, will adduct the hip. That means bring the hip back in. So it does do abduction and it does do extension. So when you're moving that leg backward and out to the side, that's going to be a lot of Glute Max. We like to use that Glute Max as much as possible. Next we have Glute Medius. Its attachments start at the lateral ilium. That's the top of the crest, or just below the lip. We're going to look just below the lip, and then it inserts where the greatest line of pull is at the lateral area of the greater trochanter, right at the tippy tip of that hip bone. So what are its actions? It does hip abduction. It does the anterior fibers, that's the ones in the back. It's kind of like the deltoid of the hip. The back ones will flex and medially rotate the hip. And the front fibers will flex and medially rotate the hip. And the back fibers will extend and laterally rotate the hip. So it can do both things. Glute medius gets used for a lot of things. Glute minimus, its attachments are, the origin would be the inferior lateral ilium. So it's got a line of attachment right around, curving around the middle of that fossa in that area. And then its insertion is going to be at the anterior aspect of the greater trochanter, so kind of around the front of the greater trochanter. So it helps with medial rotation, obviously. It helps with hip flexion, and it helps to abduct the hip. So when you're laying on your side and lifting your leg up, you're using a lot of glute minimus. Okay, and then going around to the front, the anterior hip muscle, the one that helps with a lot of flexion and medial rotation. It's also attached to the IT band, is the, let's see if we can say this correctly, Tensor Fasciae Latae. Everybody says it differently. I've seen Latae, I've seen Latae. I like to say Latae because that's what it looks like for me. But Latae is another, whatever. Just say however you want. I don't care. TFL, that's what we call it for short, because people don't like to say it. Its origin is on the front of the iliac crest, on the anterior aspect of the iliac crest. And that is behind the anterior superior iliac spine. And then it comes down to the iliotibial tract. It can be kind of a tender muscle for people if you go to work on it, but it can make a huge difference in people's range of motion and their comfort, because things get really, really tight in the front, and that puts a lot of pressure on the muscles in the back, and they have a lot of hip issues, hip aches in the posterior area if things are too tight in the front with that TFL. So that's why it's an important muscle for us to know. All right, and now we're going to look into the deep six, the lateral rotators. Those are 6 teeny tiny little annoying muscles that they're powerhouses with helping us to be able to turn our leg outward with that lateral rotation that I demonstrated. So the first one, the big one, that causes a lot of trouble because it runs right next to the sciatic nerve, or in some cases the sciatic nerve runs right through the middle of the muscle. So that's the piriformis, and its attachments are on the anterior surface of the sacrum, like deep under the sacrum. And so if you can get your fingers in there when you're working on somebody or when you're trying to find this muscle, it can be a huge relief, or it can be really sensitive. And then it comes across to attach to the superior part of the greater trochanter of the femur. And that's a huge one in helping with lateral rotation. And if the hip is flexed, like you have your knee lifted up and you go to laterally rotate, it's doing a lot of work. It's a hard working little bitty muscle, which is what causes so many problems with people's sciatic issues. And I'm going to collect these other 2 sets of muscles into the Gemellis, or Gemellis, however you want to say it. Gemel to me means Gemini, it's twins. And then there's 2 obturator muscles. So the first set, superior and inferior Gemellis. So it goes piriformis, superior Gemellis, one of the obturator muscles, and then inferior Gemellis. And I think they just call them that because they're kind of like twins, but they are definitely separate. They're not the same muscle, but they do the same kinds of things. They both just laterally rotate the hip. They both have their insertion at the medial surface of the greater trochanter, but one of them is attached to the ischial tuberosity and the other one is attached to the ischial spine. So they're twins, superior and inferior. How do you know the difference? The superior one is the one that's more proximal to the head, right? The proximal one, the higher one. And then the obturator are separated by internus and externus. So the internus one is going to attach to the obturator membrane that's deep inside this hip, and it's going to and the inferior surface of the obturator foramen. And that internus is going to be attaching to the medial surface of the greater trochanter, right there. And then the external obturator is going to attach to the ramus of the pubis and ischium, rami in plural, and the obturator membrane as well. And then it stretches over and it attaches to the trochanteric fossa of the femur, basically right next to the trochanter. And they both work the same. They laterally rotate the hip. So basically, when it comes to all the other ones except the piriformis, it's really unlikely that you're going to get tested on those muscles specifically for the MBLEx, and also the Quadratus Femoris, which is the most inferior muscle out of all of those. It's unlikely that you're going to be getting tested on these specifically one by one, but instead you might get a question where it's like, which of these muscles is going to be part of the deep six lateral rotators, or which of these muscles helps to laterally rotate the hip. And you might have, if you have something that says a Gemellis or an obturator, then you know it's one of those. But you don't have to like know specifically exactly where those attachments are going to be, just like generally, because there's just such little obscure ones. But it does really help to know the exact locations of the piriformis, because it is one that's really important. But finally, the Quadratus Femoris, that attaches to it starts at the lateral border of the ischial tuberosity, and it attaches, does like this span across the intertrochanteric, that's a lot, intertrochanteric crest between the lesser and greater trochanters. So that this little like lip right here. And yeah, that's the final one. It can get really tense. All these, that whole set of muscles can get really tense for people. And it can feel really, really good to get some deep work done in there if your clients are into it. We're moving on to the anterior aspect of the thigh, the quadriceps muscles. So the rectus femoris being the first one. There's four. Quad is four heads. So the rectus femoris has its origin up on the hip on the anterior inferior iliac spine. That's the lower bump. And then it comes all the way down and it attaches to this big fat ligament that all of the other quad muscles attach in. That's the patellar ligament, and it attaches to the tibial tuberosity all the way down here. And with all the quadriceps muscles, they're all about extending the knee, stretching that knee straight out. But also quadriceps helps with hip flexion. So if you have somebody who has is unable to stand up completely straight, unable to completely extend their hip, then that could be a sign that there's a lot of tension in that rectus femoris. Vastus Lateralis, all about extending the knee. It attaches, its insertion is at that patellar ligament, and its origin is kind of spread out between the gluteal tuberosity, which is over here on the hip. It attaches at the greater trochanter of the femur, and also the lateral lip of linea aspera. I don't have listed here that it fuses a little bit with the IT band as well. And so yeah, it's all about extending the hip. Vastus Medialis is going to be all the way on the medial side of the knee, just superior to the knee. And it is, let's see, its origin is going to be on the inside of the leg, on the inside of the femur here, on the linea aspera. And its insertion is down here at the patellar ligament, attaching to the tibial tuberosity, extending the knee. Once again, all the vastus muscles help to extend the knee. So the last one in the four is the Vastus Intermedius. So you have rectus femoris, and we have the three vastus muscles: medialis, lateralis, and intermedius. So the attachment for the intermedius, which is deep to the rectus femoris, we have the anterior and lateral shaft of the femur, and it goes down, attaches to the tibial tuberosity, and extends the knee. They all extend the knee. Quads, all of their attachments, all of their insertion. Sorry, not all of their attachments. All of their insertions is going to go down to that tibial tuberosity, and they have origins all around that femur. Hamstrings, we're going around to the posterior side of the leg. And so we have hamstrings consist of three different muscles. We have the biceps femoris, and we have the semimembranosus and semitendinosus. So biceps femoris means it's got two heads, right? Biceps. So femoris is that leg muscle, two heads. So the long head of the biceps femoris attaches to the ischial tuberosity. That's that big bump on your sits bone. And the short head attaches to the linea aspera. That's that line going down the femur. And its insertion is on the head of the fibula so that it can flex that knee and also, laterally rotate the hip. Oh yeah, so when you turn your leg inward or you turn your leg backward, that hip can rotate. So it does help with that. And then the long head helps to extend the hip and assist with laterally rotating the hip. And posterior pelvic tilt. So because all the quads attach to the ischial tuberosity in some way, they will pull that hip backward, or pull that hip forward, I guess. They'll pull it anteriorly, so the top of the bowl is pointed posteriorly. So posterior pelvic tilt for semitendinosus and membranosus. They all do that because they attach at the ischial tuberosity. Semitendinosus is going to be the more superficial and medial muscle. It starts at the ischial tuberosity, and then it goes down and inserts at the pes anserinus. And I haven't talked about the pes anserinus yet. It's called pes anserinus. It means goose foot, essentially. And that is, the pes anserinus is a spot that comes off of this flat part of the tibia. And there are 3 different muscles that attach to that pes anserinus tendon. And we're going to talk about those as we go along. But it's SGS. So Sartorius, Gracilis, and Semitendinosus. And the significance of them all attaching to that pes anserinus is it helps with that knee medial rotation, because your knee doesn't just like bend, straight, doesn't just do a flexion and extension. It actually does a medial rotation as it turns inward. It turns inward as you flex it, and it turns outward as you extend it. And so that pes anserinus tendon will pull that knee kind of like a corkscrew, turning it inward as you flex it. Okay, and of course, posterior, hip extension and posterior pelvic tilt, because it's attached to the ischial tuberosity. And it does helps with medial rotation of that hip as well. Same thing with semimembranosus. It has all the same actions as semitendinosus, except for that corkscrew knee thing, because it is not attached to the pes anserinus. Instead, its insertion is going to be at the posterior medial condyle of the tibia. So right all the way on the outside, right here. And its origin, of course, is at the ischial tuberosity, just medial to the semitendinosus attachment. Now we're going to be talking about the adductors. So the first one I want to start with is the little one, which is the pectineus muscle. And it's just this little guy that can really cause a lot of trouble if people are in a chronic holding their legs together position. A lot of women do that, but men do it as well. I've seen it plenty of times, that they're just like kind of always tense, holding their legs kind of together, they're ready for protecting themselves. And the pectineus here is the main culprit in that, and it can get really stuck. And it's because it attaches on the origin is going to be on the superior ramus of the pubis, and then its insertion goes down to the pectineal line of the femur. So it's got the shortest line of pull. My voice is going out. It's got the shortest line of pull, so it can be the tensest. So adduction, obviously. Medial rotation, bringing that knee inward, and it does help with some hip flexion as well. So it can be shortened, chronically short, from people squeezing their legs together and from being in a sitting position. Adductor longus, that's the long adductor inside the medial part of your leg. It starts at the pubic tubercle, and then it inserts at the medial lip of the linea aspera, and it's all about bringing those legs together, medially rotating the hip, and it does help a little bit with hip flexion. Adductor Magnus, that's the wide one. The long one is like long, right? The Magnus is the wide one that starts at, it's got a spread out area. Inferior ramus of the pubis, ramus of the ischium, ischial tuberosity, all across this deep pelvic area, all across this lip. And then it comes down and attaches at the adductor tubercle and at the medial lip of the linea aspera. And then, of course, adduction, medial rotation, hip flexions, and because it's so wide, the back fibers, the posterior fibers, help to extend the hip, help to bring it back. And then for another adductor, we have Adductor Brevis, which is the little one. So we have the long one, we have the wide one, and we have the little one. And that little Adductor Brevis is going to have its origin at the inferior ramus of the pubis, and it's going to insert down here at the pectineal line, the medial lip of the linea aspera. There we go, pectineal line, linea aspera. It helps with adduction, medial rotation, and hip flexion. So all those adductors, what do they have in common? Adducting, medially rotating the hip, and a little bit of hip flexion. So remember that in your MBLEx. One more adductor. This one also helps with medial rotation. It also helps with adduction. It does help with hip flexion. And because it attaches at the pes anserinus, it helps with that corkscrew knee flexion, medial rotation and the knee flexion. Gracilis originates at the inferior ramus of the pubis. That's down here low, and then it stretches down. It goes down there. Very sensitive little muscle. And then this other muscle is something else. It's not an adductor. What does it do? Hip flexes, laterally rotates, hip abducts, knee flexion, knee medial rotation. This is the Sartorius. It does all those things, but it spans all the way across the leg because it starts at the anterior superior iliac spine, and it pulls on the pes anserinus tendon. So that's the most anterior of all of the pes anserinus muscles. So its big thing is hip flexion, knee flexion. So if you just like go to flex your knee and your hip at the same time, you're totally engaging that Sartorius. And like you do a knee twist or a foot twist, and you're totally engaging that Sartorius. So we got the iliopsoas group we're working on next, and that's going to be the end of it. So these are your deep hip flexors. They're the most prominent muscles for flexing your hip. The psoas major is the one I'm going to talk about first. There it is, attaching at the lumbar vertebrae on the anterior aspect of the lumbar spine. So the bodies and the transverse processes. So it's deep inside your core. The way that we access that muscle is to go in through the abdomen to massage it. I've done it many times, and it's not something to be afraid of. You just need to be properly trained. It comes down and attaches to the lesser trochanter of the femur. And its actions are lateral lumbar flexion. So you can do like lateral flexion. You can do hip extension, you can do lateral lumbar flexion, which is like a tilt to the side. There's hip flexion. There's lateral rotation of the hip, which is it pulls the leg outward. It does anterior pelvic tilt when they are working. It can do that unilaterally or bilaterally. It's a big culprit with anterior pelvic tilt, with tilting the bowl toward the front, toward the anterior side, especially when it's bilateral, but it can do it on one side, and it can cause the glute to stick out on one side. So sometimes when you have somebody laying prone on the table and you notice one hip is higher than one side of the hip is higher, or one glute is higher than the other, it can be because one of the psoas muscles is shorter or more tense than the other. So it causes that pelvic tilt on one side. And with the leg insertion fixed, so instead of the origin being up on the lumbar vertebrae, if the origin pretends that it's down on that leg insertion, it helps with trunk flexion. It helps you to be able to do crunches, essentially. And then we have psoas minor, which a lot of people don't have, actually. Like about 50% of the population has psoas minor. It's interesting to know. It's this little bitty muscle that goes from T12. It attaches at T12 and lumbar 1, and it comes down and attaches to the pubic bone, the superior ramus of the pubic bone. And it helps with pelvic tilt and trunk flexion, and it causes hyperlordosis. That's one of the things it causes. Creates a little extra lordosis there. But, psoas minor isn't. Psoas is usually lumped together as just psoas major, or just psoas in general, because they both kind of do the same thing. So, and because not everybody has a psoas minor, we don't really worry about that too much for the MBLEx. But I threw it in there. Why not? And then finally we have iliacus. That's that muscle that spreads all the way around the the medial part of the iliac. They call it the iliac fossa, which is the inside part of the iliac. And then it comes down and it melds with psoas. I would call it the iliopsoas tendon, essentially, to attach to the lesser trochanter. So just like the psoas muscle, it helps with hip flexion, lateral rotation of the hip. It causes anterior pelvic tilt either bilaterally or unilaterally. And if the leg insertion is fixed, just like the psoas, it helps with flexing the trunk. And those are all the muscles that I'm going to be covering in the hip and thigh webinar. And all the rest of them are going to be in the last video. Those are all the lower leg and foot muscles, which is a lot. Just like when we did, you can see the hand and forearm, the hand and forearm video, which is going to be in there, where I go through and I, talk about each muscle and talk about their attachments. I probably will end up filming that in the same way as I did the hand and forearm video. And with that, we're done. And make sure and get your freebies. And if this video was really helpful to you, please subscribe. I would love that. It would mean so much to me. Give the video a thumbs up if it really helped you. And yeah, it's just great to just listen. Just listen to people talking about this stuff, and it will sink in. So with that, I'm going to close out, and I will see you guys in the next video. Whew, I'm tired. Toodaloo.